that may have cognitive dysfunction or dementia may not be candidates. So can we treat their dyskinesias with medications? And so there are two medicines. There's a number of them that have been tried, but there are two. This one is called tozatinib and etoposide, and these are two medicines that are currently being tested for treatment of dyskinesias and Parkinson's. So moving on to gene therapy, so when we talk about Parkinson's disease, Dr. Kemani mentioned a number of genes that are basically, if you have a mutation or defect in the gene can cause Parkinson's. But this is, this genetic therapy is a little different. What we are using here is a particular kind of virus. Now this virus has been rendered harmless. It won't give you a viral infection, like we get. It's harmless. There are 3 dopamine producing genes which can be injected directly. So what you have is these 3 genes for enzymes that make dopamine. This is the vector or the virus. It's called lentivector, it's just a name. And it is a large virus. You can actually put 3 genes in it and you inject it in the brain of the patients. And what you hope to do is you hope to produce dopamine in the area of the brain that's called striatum, where it is required for it to get a motor response. So where are we in the studies? They basically have done a phase 2 study. This was out of UK. What they found is that, that we are able to safely, the keyword is safely, administer the genes into the brain of patients and make dopamine, which is the missing agent in Parkinson's patients. It also smooths out, the peaks and troughs. Medicine kicks in, medicine wears off, medicine kicks in, medicine wears off. So those are motor fluctuations, and which are produced by levodopa, which is the current standard treatment. So I suppose that they will go into phase 3 studies at some point soon. So this is a therapy near and dear to my heart because I spend a lot of time studying it and practicing it. So we know that deep brain stimulation is a very good surgical therapy in the certain category of patients that are good candidates for this therapy. And Dr. Whitworth will talk about that, and so I won't say much. And we know that there are a number of different targets, one of them being the STN, or the subthalamic nucleus. This is an anatomical target in the brain that we put wires in to help with motor fluctuations, on and off, that is, and dyskinesias. So, and it has shown, studies have shown that have been done since the early 1990s, is that ST and DBS will reduce motor disability, will improve the motor symptoms, will improve the quality of life in patients with advanced Parkinson's disease, right? So if it's such a good therapy in advanced Parkinson's disease, why not study this therapy in patients with early disease and see what it does? And so that's what, this is a trial called Early STEM, and this proposed that DBS could probably give benefit at the early stages of Parkinson's. And so they did a study with 251 patients. They had early motor complications. Look at their mean age, that's 52. If you look around here, the age of people is probably a little beyond 52, right? And the duration of the disease was 7.5 years. Now in our clinic practice, I can't say, it depends on each individual patient, but perhaps 8, 10, 12 years is where we may be doing DBS at this point. And so they used DBS plus medical therapy, which is compared with medical therapy alone. And I'll quickly tell you that they found over a 2-year period that, and they really looked predominantly at quality of life. Does early DBS improve quality of life in patients compared to medical therapy alone? And they found that there was improvement in this group, and there was really no change in the medical group. And they also saw that this therapy improved motor disability, dyskinesias. Of course, we had to take this with equipoise, that this is a surgical therapy. Surgical therapy has some complications that are unique to it. So the surgical group had a higher rate of complications compared to the medical group. It's not that high, but it is high compared to medical therapy. Okay, well, what does this mean, right? DBS hasn't been shown to slow down progression of disease or confer any long-term benefit when performed early. At this point, there is no evidence. But because evidence is not there, it doesn't mean that it doesn't exist or cannot be proven in the future, right? Now, in early disease medication adjustment, you all know medication adjustment is easy to do in early disease. The response is very good. I have people that take only 1 tablet of levodopa 3 times a day along with other medications, not a lot of dosages, right? And DBS is an invasive therapy. It does have its risk. It's a personal decision whether a patient wants to do